This is Dr. J back again with the Human Movement Institute, where we have improvement through movement. I'm really excited to share today's content with you because it's a condition that I have suffered from myself, and it's been a rather nagging condition for at least a year now. However, as we learn more about human movement and human movement diagnosis, we can better match our treatment to our particular condition. In particular, when we identify the causative or etiological variables. Today we will be discussing Pronator Teres syndrome. Pronator Teres syndrome is a specific condition involving the pronator teres muscle. The pronator teres muscle starts on the medial epicondyle with what's known as the common flexor pronator group. And it runs on a diagonal to the mid-anterior to anterolateral radius for its insertion. This muscle is unique because it has two heads. And any time a muscle has two heads where a nerve can pass, it can not only lead to pain from the muscle itself, but it can cause a mononeuropathy or compression of a particular nerve. And in this case, the anterior interosseous nerve, which is the branch off of the median nerve. This condition can often confuse both patients and clinicians because it can mimic in some ways carpal tunnel syndrome. So let's make sure we're not getting carpal tunnel releases for patients who have Pronator Teres syndrome. So what are some exercises I can do to treat and resolve this condition? What are some of the findings from this condition? Well, in the less severe cases, it might simply be tenderness simply along the Pronator Teres. And when you activate it or contract it into forearm pronation, you might find that you can reproduce some of the pain in the forearm or referred pain down to the wrist and or hand. As the condition progresses and the anterior interosseous nerve, aka AIN nerve, is compressed, you can get pain and paresthesias into the thumb, index finger, or even slightly into the palm of the hand. You can also reproduce the symptom as you do median nerve quick tests. If I put the median nerve on tension and side bend my head away to tension the nerve, it may reproduce some of your symptoms. Also, if you tap on the Pronator Teres and it reproduces distal symptoms that mimic your symptoms, we now have a good case that you have Pronator Teres syndrome, Pronator Teres involvement. So back to what we should do for exercises. First, this muscle is often involved in patients who have to do repetitive, excessive forearm rotation movements, particularly forceful pronation. So I'm thinking of people like mechanics. I'm thinking of people who have to pick boxes or objects up and rotate the forearm repetitiously throughout the day. I like to start with mobilizing the Pronator Teres first. I can do this with forearm on ball, or I can do ball on forearm. Find the medial epicondyle, go down and in, or inferior lateral, and find the Pronator Teres. To know that you're on it, rotate your forearm from palm and forearm up to down, and you will feel the superficial head of the Pronator Teres. You can start with least severe or least aggressive or lowest dosage with rolling along fibers. Then you can progress to cross fiber rolling. Don't be discouraged, alarmed, or worried if you reproduce some of your radiating symptoms, as the treatment would confirm the diagnosis. This would let us know that the restriction within this muscle needs to be addressed. To progress muscle mobilization, we can now tack and twist and shear. So I can tack, twist clockwise or counterclockwise, shear with muscle and or cross muscle. This is often painful at first, so you control the dose, start light, progress to deeper or higher dose. Initial starting dose, 2 to 5 minutes, once a day or every other day. In between mobilization, we will want to practice full elbow extension, pronation, supination. So after I do a minute or two of mobilization, I do 20, 30 forearm pronation to supination motions. Then back to another round of mobilization to tease out any remaining tightness, tenderness, or restrictions. Next is Pronator Teres stretching. This is a challenging muscle to stretch correctly. We need to have full elbow extension, cubital fossa anterior. So I'm distracting my elbow by pulling through the radius and ulna and rotating the forearm up into supination. I'm maintaining full extension. An initial starting dose is to hold for 30 seconds to a minute, 2 to 3 times, twice a day. Personally, I like to use end range contract relax technique to get deeper into the muscle and to allow for sarcomere give. So I have full supination. Now I'm doing audiogenic inhibition, pronating the forearm, relaxing back into supination. Conversely, I can do reciprocal inhibition by resisting forearm supination, thereby activating the supinator muscle to further release or inhibit pronator teres. This would be our initial treatment for this condition to help decompress AIN nerve, to help release any trigger points or pain from the pronator teres. If you've liked this video, please share it with your friends, family, patients, and colleagues. Take care and see you all again soon.